right, we'll go ahead and get started. So first off, so my name is Cameron Hilt. For those of you who may not know me, I am the new program director for the Upper Midwest Telehealth Resource Center. And we're happy to have with us today Zach Ward, who's an assistant professor of health administration with the University of Southern Indiana. That's going to give us a deep dive on provider burnout and the electronic health record. So thank you so much for joining us today. And Zach, I'll go ahead and hand it off to you.
Great. Well, thanks so much, Cam. I appreciate it. And Carolyn, too, for coordinating this. So as Cam just said, today I'm going to kind of focus on the electronic health record and provider burnout. Interestingly enough, this was my dissertation topic a few years ago. And the joke always is that I tell people is that I got burned out by writing about burnout. So hopefully that doesn't happen too often, but it definitely can, particularly when you're writing something that takes a couple years to do the research and everything else on. So today's learning objectives, I'm going to focus primarily on these three learning objectives, but we're going to focus on what burnout is and how it's measured. We're going to also understand the significance of provider burnout in the United States and the healthcare system. And then the third objective is identify the role that the electronic health record may actually play on provider burnout. And perhaps some ways, I want to discuss a couple ways that we're starting to see pop up in the literature as ways to mitigate that burnout. So what is burnout? Well, there's the main definition that we all come back to in the literature is Christine Maslach's three dimensions of burnout. 1981, she wrote a big article. I'm going to discuss a little bit more about her article here in a little bit, but she came up with these three dimensions: emotional exhaustion, depersonalization. So depersonalization is really detachment of the job, and then lack of personal accomplishment. Interestingly enough, just a few years ago, the World Health Organization recognized burnout. They actually published it in the ICD-11, which is the International Classification of Diseases. But they discussed that, or they described burnout as a syndrome conceptualized as resulting from chronic workplace stress that has not been successfully managed. And I think we can all say during COVID, we kind of felt that a little bit, right? Some questions that or at least one question that I hear a lot when I go out and speak about burnout is, how's burnout different than stress? And I come back to a Psychology Today article written a few years ago that kind of focused on the differentiation. And it really has stuck with me. But stress, the important thing to, I guess, understand is stress is episodic, right? What I mean by that is it comes and goes. A perfect example is, here at the university, I just gave a class, have a class of 60, and I gave an exam on Thursday. And so I had a lot of stress to get that graded before we left for fall break. But it went away. And when that went away, after I was done grading, I wasn't stressed anymore about that. But burnout really doesn't go away like stress does. It's not episodic. We feel those feelings, right, of exhaustion or detachment from our job, and they really don't go away. So sometimes we look at stress and we look at burnout, we describe them as one and the same, but that's really not the case. So what does burnout look like? I discussed a little bit about the definition, but sometimes we see folks are cynical about their work. Sometimes they have a lack of energy or enthusiasm about their work. They have negative attitudes, and those attitudes that surround maybe the work can also bleed over into the personal life. And we see that happen frequently. Negative feelings about work productivity, negative feelings about work team cohesion. So you can kind of see that these are some of the main symptoms, if you will, of what burnout will look like. So how do we measure burnout? And this is where I'm going to come back to that Christine Maslach article from 1981. In that article, while she defined burnout, she also described the inventory which to measure burnout. And this has been deemed in the literature as the gold standard of measurement, the Maslach burnout inventory. 1981, it measures those three domains, and there's 22 questions. But wait, there's more ways of measuring burnout. There's the Copenhagen Burnout Inventory, came out in 2005. It measures three domains, but it's 19 questions. And these three domains of the Copenhagen Burnout Inventory are a little bit different than what Maslach had proposed with the cynicism and detachment. We have the Mini Z. This is came out again in 1981, but this is really one question, and it's overall based on your definition of burnout. How would you rate your level of burnout? So just one question, as opposed to the numerous questions, but then numerous question inventories on the other two there. And then we have the Oldenburg burnout inventory, 16 questions, and this measures two domains, which is disengagement and exhaustion. So as you can see, we have a few different ways of measuring burnout. We've even kind of described that it could be defined maybe a little bit different too with those inventories. So it's kind of created a little bit of an issue as to measuring and defining burnout. There's some literature that's been published, particularly in the last few years, that's been critical on the subject. We're saying everyone's burned out, but we really don't have a uniform measurement or a uniform definition. And so when I think of that, I think of temperature, right? I was able to find the stock photo of a little boy playing with a thermometer. But if you have a sick child or you're ill or something like that, you typically take your temperature, right? And it gives you either Celsius or Fahrenheit, but it always translates back to a temperature. But it's really hard to determine if somebody has a fever if somebody, you have 4 or 5 different people maybe using their hand to determine a fever. There's a little bit more variability, and that's kind of what I'm getting at here. We've also seen some of the journals come out and take a little bit stronger stance about the burnout literature, particularly when it comes to measurement. One example is the journal Graduate Medical Education. They've kind of taken the stance that you can't call burnout unless you've actually used the MBI or the Maslach burnout inventory as the assessment the assessment or inventory. So kind of shifting here a little bit and looking at the growing level of research and getting to that second learning objective that I have, understanding the significance of provider burnout, we begin to see that there's a huge growth, and I'll get to that in a minute as far as what the chart looks like, how much we've seen published over the last decade. But these are kind of some what I call the key points of the research. In 1974, we see that the term burnout was actually coined for the first time. Down here in 1981, the literature and the research surrounding the Maslach burnout inventory by Maslach and her colleague Susan Jackson. In 2005, we saw the first article really that tried to understand the relationship between burnout and stress and patient outcomes, which is pretty significant in its own right. 2014, the triple aim, which we've all heard of in healthcare, was actually proposed to become the quadruple aim by adding improvement of work life of healthcare providers. 2019, we saw the World Health Organization come out with a new definition of, or actually defining burnout as a workforce phenomenon or workplace phenomenon. Physician burnout is actually labeled a public health crisis by 4 leading healthcare organizations, Harvard, the Boston Medical Society, and a few others. They're pretty renowned in their own right. And we saw the first known article that actually studied the financial implications of physician burnout on health systems. And then 2020, well, we all know that really is when COVID took root in our own lives and really changed the trajectory of about everything. And there's still a lot to learn about how COVID has disrupted workflows, changed the workforce as we know it, and everything else. I actually pulled this grid out of PubMed, or this table, if you will, but this is kind of an indicator of, if you type in burnout, how many articles have been published in medical literature over the last few years. I think it's specifically physician burnout, but as you can see, just hardly anything. And then we see a real big uptick between 2010 and 2020, a significant growth. And I think that's going to grow even more, right, because of COVID and what we're starting to discover there. So what are the consequences of physician burnout? And here's really 3 domains, and this is according to West and colleagues. Patient care is one of the areas that's affected by physician burnout. We see that physicians are actually making more medical errors. They have lower patient satisfaction scores and have a diminished quality of care if they experience burnout. But we also see impacts on health systems. There's greater physician turnover, reduced physician productivity, And those actually have an increased cost. If you've worked in a health system, and primarily if you've done physician recruitment, you understand that health systems spend a ton of money recruiting physicians, and this is a constant uphill battle. And so then if you're constantly recruiting and then those physicians leave, you have a net gain of zero at that point. So it's extremely expensive. There's actually one, actually, I'll go back real quick as I'm talking. There was one study that published or that looked at the cost of physician recruitment cost for, I think it was family medicine. So for to replace one family physician, it takes anywhere from $600,000 to about $1.3 million by the time you factor in all the externalities that go into replacing a physician. So it's extremely expensive. But also too, there's the physician's personal health that we have to look at. There's issues of higher rates of substance abuse, poor self-care, and higher self-harm ideation in physicians who are experiencing burnout. Back to the costs for a minute, because this is something that's intrigued me a little bit. Because I come from healthcare primarily, I did a lot of physician recruitment where I came from. We see that, and this is actually from a few of those articles that have been published over the last few years, but we see that medical costs cost health systems about $20 billion annually. That's extremely expensive, right? Healthcare systems spend about $4.6 billion annually in recruitment of new providers. And so we also see that also factors into missed referrals, catch up the pace of a new physician when they're replacing a physician that has left. And then also too, patient satisfaction costs go into that. We see that patients actually are good marketing tools, right, for health systems. And if a patient has a bad outcome, it doesn't take a whole lot to go to Google and write a review or call up a friend and say, I would never go to that orthopedic surgeon because they messed up my knee or whatever it is. But word of mouth definitely has a value to that. We also see personal cost again. We see physicians tend to retire, leave the profession earlier if they're experiencing high levels of burnout. And it also obviously affects personal quality of life with friends and family. Now, kind of switching now to the third learning objective I had, which was to kind of focus on the electronic health record and its impact on physician burnout. Over the last few years, we've seen growing articles, not only in the academic nerdy journals, but we've also seen it break through in the mainstream media. And these are just a few articles I pulled in the last year or so, but we see that the New Yorker, NPR, and the New York Times Magazine has kind of picked up on this idea that doctors are spending a lot of time behind the computer screen and really examining, is that good? Now, before I go in and talk about the negatives of EHR and its impact on physician and provider mental health and the workforce in general, there's been a lot of positives with EHRs. I worked in a health system that implemented Epic, and I remember 10 years ago when it was just nothing but paper charts and pulling those charts, because I started out as a phlebotomist when I was 19 years old in the hospital. So working the night shift, pulling charts, putting labs in, and then making sure that the pathology reports and everything was there. There's definitely been a lot of positives that the electronic health record has brought, right? You're able to do order entry electronically, prescriptions, anything like that, you can send to the pharmacy with the click of a mouse. Clinical decision abilities. We're seeing a lot of add-ins now with the EHRs that help clinical decision making with providers. The health information exchange, this is something I know that we're constantly working on in healthcare, but it's getting better. We're able to send more information to other providers for patient care and patient safety. Very concise documentation now. No longer do you have real thick paper charts. It's all concisely into the record. We're also seeing a lot of enhanced quality, right? It goes back to the health information exchange and those clinical decision abilities. But because of those, while we do have positives, there's also some negatives, obviously, that come with that. We saw in the very beginning, it was very expensive to implement EHRs. Numerous health systems, particularly those that were smaller, maybe at a medium cap, some actually unfortunately closed after incurring a lot of debt because of the EHR implementation. EHRs are extremely expensive or intensive rather for maintenance. We know that from the health system I came from, the IT department during Epic went from about 40, 50 individuals to about 200 in about 5 years after implementing Epic. You have to grow your workforce in order to for the maintenance of that and to keep it going, that software. Also, too, we heard a lot of physicians and providers kind of indicate, that their workflows were disrupted significantly, and they had to change their workflows permanently because of the EHR implementation. I also put data overload, and I think sometimes you think that we have all these data, we have all these metrics on patient care. That's great, and it is. But sometimes I think we also have the ability to become overwhelmed by that data, and we're so focused, so centric on every data metric or data point that it becomes irrelevant after a while. I'll go back to the temperature. You can track a patient's temperature in the EHR maybe every 10 minutes. And maybe there's a clinical reason for that, maybe not. So we become so focused on this data and entering all this data in that sometimes we have the ability to really overwhelm ourselves and our colleagues with that data. And then the ability to work everywhere. During COVID, that was a great positive, right? We got to work from home, we got to work from bed if we wanted to, but that's also a negative, right? And what I mean by that being a negative is that we've actually, what we found is that we kind of need boundaries with our work. I know if you're a parent or something like that, you kind of need set time, family time, work time. My wife is a cardiac nurse practitioner, and I would tell you she brings home a file folder. It's probably that thick every night of charts that she needs to catch up on. And weekends are spent usually Sunday afternoons when the kids are out playing and I'm mowing the lawn or something like that. She's in the house sitting at the breakfast table working through her chart. So the ability to work from everywhere is great, but also too, it's kind of a curse as well. So what are we hearing from providers? We hear the term clerical burden a lot in the literature, but also too from our provider interviews. We hear pajama time. This is something else too that's made its way into the literature, the lexicon. But pajama time, when I'm supposed to be in my pajamas in bed, I'm actually in my pajamas in bed with my computer open, documenting. Less patient interaction. We hear this from the providers. We also hear this from the patients. Every time I go to the doctor, he or she is looking at the screen. They're not looking at me. Click fatigue. There's been some studies done out there on the EHR and actually monitoring or keeping track of how many times a provider clicks the mouse. And several times you've got to click a mouse to interact with the EHR file. We also hear from physicians that it's inefficient, right? I think that may get back to the data overload point that I made earlier. Any tool is great until it becomes too much, and then it becomes inefficient to operate. It's very time consuming, obviously, too, not only from the time that you spend in the clinic, but also to that pajama time. And cumbersome, we hear that as well. So what's the literature saying specific data points about the EHR? We know that EHR related stress is extremely common and primarily affects primary care. We know that on average, physicians in general spend about 16 minutes per patient in the EHR, and that's in the outpatient setting. But kind of going back to primary care for a moment, we know that family medicine physicians spend about an average of 86 minutes documenting after clinic hours. That's about an hour and 20 minutes, right? That's an hour and 10 minutes. Apparently, I just showed I can't do math. Sorry about that. But that's significant. If your clinic ends at 4:30, that means that you're documenting till about 5:40 at night. So, going back to being a parent and getting back into the routine of after work, you have errands to run, your own personal life to attend to, it becomes cumbersome. And this goes without saying, but after hours charting was associated with higher physician burnout. So I'm going to kind of discuss really quick here two ways of, or two immediate fixes, I guess you could say, to reduce physician burnout with EHR. Obviously, we've seen that there's been a huge, a lot of the documentation requirements aren't driven by us. They aren't driven by maybe one particular health system, they're driven by federal compliance issues. So without specific legislative, some sort of recourse or address from the top, it becomes extremely difficult to mitigate some of these documentation requirements. But here's a couple, I guess what you could call immediate fixes that you could start implementing into your clinic or into your practice. We know that scribes in the literature had really had an impact on burnout reduction. A couple studies here I'll reference. In 2017, it was the first known study on scribes. Scribes significantly improved physician satisfaction, improved documentation accuracy, and improves patient satisfaction. Looking to last year, there was a study done of just oncologists alone. And 90% who used scribes reported increased time with patients and computer time. They also, every physician oncologist that took part in this study or indicated that they would, that scribes improved their quality of life. Where I came from, the emergency department and oncology utilized scribes, and it was done mainly for a productivity standpoint. It was also done as a satisfaction from a provider satisfaction standpoint as well. And they have, and it went well, and those physicians actually indicated that they enjoyed having the scribes there. Now, obviously, too, I've interacted with several physicians who say that, I don't want a scribe. They can't describe, they don't know what I'm thinking. How do they know that I'm going to ask this versus that? And once again, there's definitely that side of it too. However, what it seems like, at least reflecting the literature, and I've been saying that a lot, but that's really the only thing we have to stand on that, and what surveys, studies we do by interacting with physicians. It's definitely better. This is definitely better than nothing, right? The other point of, I guess, implementation I will discuss is a team approach to healthcare. Now, where I came from, the big buzz was always using those clinical folks, those MOAs, medical office assistants, those nurses, those folks at the highest level of their license. And so what we see that, we kind of discussed this, but also too, there's some studies out here backing this up, is delegating some of the documentation duties to other folks in the clinic that are licensed to do so, can actually reduce or alleviate the documentation burden that's placed on physicians. In the dissertation that I wrote, I particularly remember one physician who commented, and you have about 250 characters to type something, and whatever they typed, it went well beyond that. But one of the points that stood out was they said, I went to medical school, and now I'm basically an order entry clerk. And I can see the frustration there, particularly when you have pressure from administration, pressure from your own colleagues to see more patients. You have pressure from patients to see more patients. It's very disheartening when you call your primary care physician with a sore throat and you can't be seen for 3 days. And so those productivity metrics are weighing on providers. So they definitely have those, the push, if you will, to get more patients through. So by having that team approach, it can definitely reduce the documentation burden placed on the physician. Also, too, it goes without saying, making sure that your IT department, your information technology department, has a good support team. Where I came from, we were very fortunate, too, that the IT department was right above the family medicine clinic that I worked in. And I was there basically to oversee the development of a family medicine residency program and hire some folks to do that. But as we hired new physicians and that sort of thing and brought them in, the IT department, having the IT department directly above us, we were able to call and get a few favors that maybe if we were at the hospital or another clinic location, we wouldn't have been able to do. So it goes without saying, there's actually some studies out there too that kind of reiterate or kind of support that claim that if you have a comprehensive IT department available and have adequate support. The other thing that our health system did too is they had folks from the IT department actually sit in the physician's lounge in the morning. That's probably the busiest place in the hospital, is the physician's lounge, between 6 o'clock and 8:30 in the morning. So they were always there in the physician's lounge, ready to help as well. And two, it goes without saying, just reducing the clerical burden of documentation on providers. So everyone, that's kind of a quick run through. It's always a little awkward doing these, in your office by yourself, and you hear yourself talk, and you're not able to see if other people are nodding their head or going to sleep or whatever they're doing. But I'll kind of turn it back to Cam and Carolyn, and if you have any questions or anything like that, I'll be glad to answer them the best I can.
Thank you so much, Zach. Feel free if you have any questions, to go ahead and place them in the chat, and we can have Zach kind of talk about them while we're all here together. And I can kind of kick us off while we see if any additional come into the comments. When you were going through the graph, I believe it was the PubMed publications looking at the different years.
Yeah.
Thought it was interesting that, yeah, we've seen that sharp spike, which we can kind of easily attribute to COVID. But what kind of started that initial increase around like the 2010 timeframe?
Yeah, sure. So I think it was around 2005, and I'll have to go back and look at my notes here, that we started seeing, we saw the MEMO study come out where it's exploring stress and burnout effects rather on patient outcome. And then that kind of really kicked off a lot of the medical, a lot more focus on physicians. And my own personal hunch to this is that we, I guess over the last decade or two, we've really started to embrace talking about our mental health more in the workplace than we have before. I would just, in my own friend groups that, we'll go fishing together or something. I have a few friends that will do that. Actually, I was fortunate enough to be with a dear friend of mine and go fly fishing in Maryland this past weekend. We talk about work, we talk about our kids, we talk about the stresses involved in that. And he's a physician, works in a very stressful department. But I would tell you, probably 20 years ago, I think of folks like my dad's generation, they probably didn't talk about that as much. So I think we're becoming a little bit more aware of that, and we embrace it a little bit more than we have. And definitely, too, you're right. It's interesting that, so this stopped at 2020, right? And what's interesting about 2020 is that's when COVID got really hot. So I'm really I'm going to, maybe make a bet that we're going to see this a lot higher in the next few years for sure.
Absolutely. No, thank you for that. I see that we got a couple questions in the chat. So one is saying, so as for what you had on what are we hearing slide, what was the last thing identified?
Okay. Gotta go back here. Cumbersome.
Yes. Okay. Cumbersome.
Yeah.
And then another question is, what things, Lance? Yeah, you caught that as well. So Brianna asked, what things specifically were most beneficial or most supportive from the health information team, along with being available in the provider's lounge in the mornings before patient appointments?
So the one thing that I noticed was when Epic first was implemented, right? And this was about 10 years ago. And I'm just using Epic, and be any EHR. I don't want Epic doesn't pay me. I'll make that clear. I don't work for Epic. But when the EHR was being introduced, there were consultants that came in, obviously, and they basically were a team with every clinic to make sure that implementation went okay. When a new provider came on board, they were basically told, hey, we have a team, usually two, they call them provider support individuals that stayed in the physician's lounge. But then they came to the clinic too for that initial week to make sure that they understood the workflows. And then also, when the EHR went through an upload or a different version, they also had support individuals available. And I'm not trying to say that our organization did it perfectly, because there was a lot of issues there always is issues surrounding the EHR, obviously, and particularly when you're impeding physician productivity and that sort of thing. Rightfully so. Physicians have a lot of folks that they're trying to appease and get through the process as quick and efficient as they can. But it seems like when a new implementation or a new phase of that version or that software came out, having those support individuals kind of there, because I can tell you right now, you can say we have a support individual available via phone. That doesn't go over well. I think we all know that, right? Nobody wants to call a 1-800 or, the IT tech support and listen to the music in the background when you've got 12 patients and it's 2:00 and you can't get something, to work. Very stressful times. If you've worked with physicians, you definitely know that. So by, having those support individuals available, but also to, what I found those support individuals did is they actually gave physicians their own personal cell phone number, and they were available all the time. There's even one really sweet person I used to work with. She gave her cell phone out and she would answer on a Sunday afternoon. And so just kind of walking them through it, just having that voice and having that reassurance really went over well.
Well, if that's it, we'll go ahead and conclude our time today. But I want to personally thank Zach for coming out today and giving us this presentation.